Hello everyone. Today we will discuss about eclampsia. It is defined as a new onset generalized tonic-clonic seizure or any unexplained coma that occurs in a pregnant woman or in labor or during postpartum. And it is associated with features of preeclampsia, and we have to make sure that other neurological causes must be excluded. So eclampsia is diagnosed when a pregnant or postpartum woman develop new onset seizures with hypertension and/or proteinuria or systemic features of preeclampsia, and there is no alternative cause that explains this convulsion. And atypical eclampsia may occur without severe hypertension or proteinuria. So, how do we classify gestational hypertension, preeclampsia, severe preeclampsia, chronic hypertension, and chronic hypertension superimposed with severe preeclampsia? So, gestational hypertension is any BP greater than 140 by 90 mmHg after 20 weeks of pregnancy with no proteinuria. Whereas preeclampsia is hypertension plus proteinuria or any systemic involvement. Then severe preeclampsia. Severe hypertension or CNS, liver, renal, or hematological involvement. Chronic hypertension is hypertension before pregnancy or in pregnancy less than 20 weeks of gestation. Chronic hypertension with superimposed preeclampsia is worsening BP plus new proteinuria plus severe features. So coming to proteinuria and edema. The glomerular endotheliosis increases the permeability, and this results in greater than or equal to 300 milligram per 24 hour or edema. There will be capillary leak which will result in decreased oncotic pressure. Edema will be present in face, hands, legs, and sudden weight gain will be there. Coming to the clinical features, it will present with headache, blurring of vision, scotoma, epigastric and right upper quadrant pain, nausea, vomiting, breathlessness, sudden facial or hand swelling, and it will have hypertension, proteinuria, hyperreflexia or clonus, edema, oliguria, and fundus showing vasospasm. So we have to do CBC and platelets, creatinine, uric acid, electrolytes, urine protein, AST, ALT, LDH, and bilirubin, PT, APTT, fibrinogen, D-dimer, peripheral smear, fundus exam, and ultrasonogram for fetal growth. Coming to differential diagnosis, so it could be due to epilepsy, CVT, intracranial hemorrhage, PRES, tumor meningitis, could be due to hypoglycemia, hyponatremia, hypocalcemia, or uremia. Drug overdose and alcohol withdrawal can also be the differential diagnosis for seizures in preeclampsia. Maternal risk factors include primi gravida, age less than 20 or greater than 35, family history, and obesity. Previously existing medical factors like chronic hypertension, diabetes, CKD, systemic lupus erythematosus, or antiphospholipid syndrome. Pregnancy related like multiple gestation, ART pregnancy, wrong interpregnancy interval, and low calcium intake. Maternal complications include cerebral hemorrhage, Helfer syndrome, acute kidney injury, pulmonary edema, placental abruption, DIC, and aspiration pneumonia. Fetal complications include IUGR, oligohydramnios, prematurity, fetal distress, and stillbirth. Generalized tonic-clonic convulsion caused by cerebral edema and autoregulatory failure consists of four classical phases. So premonitory, which is it exists for a few seconds, which is an aura. There will be facial twitching, eyelid flicker, eye deviation, small jerks, and restlessness. Tonic phase will last for 10 to 20 seconds with generalized rigidity, hyperextended neck, fixed thorax, which will result in apnea or cyanosis. Clonic phase, which will result in duration of 1 to 2 minutes with rhythmic jerks, frothing, tongue biting, gasping respiration, and cyanosis. Whereas the last stage of coma, which can occur for minutes to hours, there will be unresponsiveness, deep breathing, returns, confusion, agitation, and risk of recurrence. Aspirin 75 to 150 milligram for 12 to 16 weeks in case of high risk women. Calcium 1 to 1.5 gram per day for low intake population. Chronic hypertensive control with labetalol, nifedipine, methyldopa in case of pre-existing hypertension. Antenatal surveillance like BP, urine protein, and fetal growth, and this is for all pregnancies. Coming to the immediate management, mother should be In left lateral position, maintain airway and suction secretions, oxygen of 8 to 10 liters per minute, prevent the injury, establish IV access, and restrict the fluids to 80 to 100 ml per hour. With loading dose of 4 gram IV over 5 to 10 minutes, 10 gram IM, 5 grams in each buttock. We are following Pritchard regimen. Maintenance of 5 gram IM every 4 hours. Monitoring the respiratory rate, if it is greater than 16 per minute, urine output of greater than 25 ml per hour, and patellar reflex pressure. And if there is additional seizure, then additional 2 gram IV magnesium sulphate is prescribed. And 10 ml of 10% calcium gluconate IV is given as an antidote. Coming to the blood pressure control, levodopa is the first line, hydrolyzin is alternative, and nifedipine oral if oral route is feasible. The target BP is 140 to 160, systolic and diastolic 90 to 100. And fluid monitoring, there should be strict input-output sorting, catheterize the bladder, hourly urine output, and continuous maternal monitoring. The definitive treatment for delivery. So when to deliver? Only after stabilization and immediately if recurrent seizures is present, uncontrolled hypertension, abruption or health syndrome or fetal distress is present, then immediately. Vaginal mode is preferred if cervix is favorable or as LSES if obstetric indications are there. Coming to the intrapartum, continue the magnesium sulfate, avoid fluid overload and continuous monitoring is suggested. Coming to the postpartum care, continuous magnesium sulfate for 24 hours to prevent recurrence. Monitor BP, urine and respiration to detect any complications. Managing the renal and lung complications to prevent morbidity. Continue antihypertensives to prevent BP control. Counsel for future pregnancies for risk reduction. So, to summarize, eclampsia represents the severe end of hypertensive disorders of pregnancy characterized by sudden onset of generalized tonic clonic seizure in a woman with features of preeclampsia. So it arises because of widespread endothelial dysfunction, vasospasm, and loss of cerebral autoregulation, which will lead to vasogenic edema and cortical irritability. Diagnosis is primary clinical, that is hypertension, proteinuria, and systemic involvement, supported by laboratory abnormalities such as elevated liver enzymes, thrombocytopenia, and renal impairment. Eclamptic fit progresses through four distinct phases, each illustrating cerebral irritability and impaired neuronal control. Those include premonitory, tonic, clonic, and post-ictal coma. The condition carries significant risk, including health syndrome, cerebral hemorrhage, acute kidney injury, placental abruption, fetal complications like growth restriction, and hypoxia. So, the management centers on rapid stabilization of the mother, seizure control with magnesium sulfate, controlled reduction of blood pressure without compromising the uteroplacental perfusion. Fluid restriction is essential to prevent pulmonary edema, and continuous maternal fetal monitoring guides the ongoing care. Delivery after maternal stabilization is the only definitive treatment. Prevention plays a crucial role where low dose aspirin in case of early pregnancy, calcium supplementation in low intake population, and optimization of chronic hypertension significantly reduce the burden of this disease. I hope you learned from this slide, and I will be putting up this presentation in the description through Google Drive link. Feel free to use this presentation. Thank you for watching the video.